here to present this. I'm here to present this topic, which is sonography of the lower transverse incision, Cesarean section. I'm sure a lot of you are wondering what is it and what is it that I'm going to talk about. And others, those who have been working, they realize that patients who have undergone Cesarean section, at times they are brought to our department, and we are required to do a scan. So I picked on this topic simply because sometimes we have to go away from the routine. Sometimes we do the routine every time. You have to check the normal things and stuff like that. And I've also realized that when something unusual comes, sometimes you don't even know what to write as a sonographer, as a radiographer, simply because you may not really know exactly the clinical question and what exactly is being asked. But I'll try to explore some few indications and reasons why patients who have undergone Cesarean section are brought to our department. And not only that, you also realize that complications may arise after Cesarean section. And it's very important that even before we answer the clinical question from whoever sent that patient, it's very important to understand the mechanism of the pathophysiology and whatever has been brought to us. And knowing that, you have to understand what Cesarean section is. We are not trying to train you as the gynecologist and surgeons, no. But the fact that we are a team in the clinical setup, we need to understand some of these things and realize our role so that we can see. You agree with me that clinically, or clinicians, they don't see everything. So sometimes they need the imaging department to come in and head that diagnosis. So it's a very short discussion, and I'll be very brief and straight to the point. So I'll give an overview or the introduction of this. I'll try to define what Cesarean section is, and basically the types and their complications and advantages, the role of ultrasound in Cesarean section, and some common findings, and then I'll conclude. So Cesarean section, it's a primary Cesarean section is currently one of the common mode of delivery that is being done in most of the centers or high-risk centers. And approximately 15 to 20% of pregnant women, they decide, others, they tend to undergo Cesarean section. The indication for Cesarean section may range from fetal distress, disproportional pelvic of the baby. The patient may also present maybe with premature rupture of membrane, and you can have quite a number of complications that may come. It could be due to obstructed labor and all those. So clinicians may decide to go and do a Cesarean section based on a variety of indications. And while they are doing that, some common complications may arise while such a procedure is being done. And some of the common common complications that may arise is, one, you can have infection. Remember, one of the golden rules in the theater is that there must be a septic environment so that there is no infection or any contamination of instruments. It's a sterile environment. So sometimes due to poor techniques, due to poor procedure practice, people may end up having infection. And remember, you've opened this uterus and infection may easily find itself into the uterus. So infection is one of the complications, and the patient may have this infection and it may actually lead to septic shock depending on how severe the infection was. And then you can have things like hemorrhage, and this hemorrhage may arise due to uterine atony. And uterine atony, it's basically a situation where the uterus cannot contract to its normal extent. Remember, when the uterus contracts, it has to also relax and go back to its normal. So this is the uterus which has been cut and it fails to contract back to its normal extent. And you can have this bleeding that may end up finding itself into the paracordic gutters, paraviscal spaces. And during that procedure, it's very important that they aspirate whatever bleeding may be happening there, so that they don't leave that bleeding, which may end up being clots. And so these are some of the things that has to be understood. And these hematomas can form in the anterior abdominal wall, right on the incision site. Hematomas may form there, and a soft tissue ultrasound may also help to evaluate the area of the incision. Extraperitoneal hematomas may also arise. These are things that you can see when you are scanning. You start seeing like you have these hematomas around and within the peritoneum, and then the extraperitoneal space. Paraviscal spaces being adjacent to the uterus. These are some of the common areas, again, where you can find hematomas, which may be significant or insignificant, depending on the size. This may arise from there. You can also have subfascial hematomas, which may also arise from that point of incision, which may come. Again, you also realize that I've talked about this transverse incision of the urinary bladder that may also arise. So this transverse incision, there are two types of cesarean section. One is vertical, and then the common one is also the transverse incision. They've got their own advantages. Like I mentioned, we are not training as gynecologists, but I think some basic knowledge is very important to understand. Literature has continued to confirm that transverse incision is very good because it avoids, it doesn't have the risk of nerve entrapment as compared to the vertical side. And not only that, this transverse incision also, it's easy to perform because you are able to approach the uterine wall within the space. So basically you find that clinicians or surgeons, they prefer to go that transverse incision. However, it has a complication where it's possible to have a bladder flap hematoma. And these are the hematomas that may exist between the anterior uterine wall and the posterior wall of the urinary bladder. So we have to be aware that despite the preferred type of incision, it also comes with its own challenges. So why sonography, and why should we talk about sonography? So sonographic findings of both hematomas has been described in most of the books, but currently no data on the normal sonographic findings of the normal incision site has been. So research is being done. People are doing quite a number of research concerning this, but these are some of the few things that we can do as sonographers, as radiographers, and those of us who are practicing. I think it's something that is doable and people can do and assess. But what is key is that the distinction between significant and insignificant changes is very important to realize on the site of incision. And sonography tends to play a role to help us realize whether the site of incision, be it right on the anterior uterine wall and right within the anterior abdominal wall, is okay. Remember, they use sutures to suture the incision site. So sometimes because of those sutures, we may find certain appearance sonographically on ultrasound, and we may think there's an hematoma or there is this or that, but it's very important to give a distinction between the normal changes of the post-Cesarean uterine incision site and those that may appear to have significant hematomas. Sometimes the clotting mechanism around the incision site may not be adequate. So you tend to have small hematomas which may be insignificant, and those can be at different levels and sizes, and they may be insignificant, but hematomas may also be larger and they may be significant. It's also very important to remember that patients may be symptomatic or asymptomatic, and based on the symptomatic and asymptomatic, patients may present differently. For example, those patients who may be symptomatic may have things like leukocytosis, they will have fever of unknown origin, and they also have other laboratory parameters. So it can give an indication to say, oh, something is going on, and you are likely to find certain things that may come in. I should mention here that symptomatic patients who presents with the fever of an unknown origin or dropping hematocrit may often be difficult to evaluate clinically, and differentials may arise from endometritis. It may arise from retained product of conception, thrombophlebitis. It can also be due to a lot of things. So clinicians tend to wonder now, what's really going on and what are we supposed to do? So it becomes a puzzle because they know exactly what has happened, but do we really know exactly and the actual treatment that we need to do? So you may talk about endometritis. How can this endometritis arise? Remember, I talked about the sterile environment. Sometimes due to poor techniques of cesarean section, you may end up having this endometritis due to infection within the endometrium. I think we are also aware of scar endometritis, sometimes due to the incision site, be it on the endometrium or be it on the uterine wall or just on the anterior abdominal wall. You are likely to have that endometritis or scar endometritis. Retained product of conception, sometimes you may not do an adequate job to evacuate all conception products from the uterine. Sometimes patients may also present with urinary or respiratory infection immediately after the post-operative cesarean section. Thrombophlebitis, this may also be due to thrombus within the vasculature, and this may also present with patients like that. A patient may be brought for peripheral vascular ultrasound, and you are required to perform this. So there are quite a number of things that they may be having and ideas, and they have to rule out them by doing the appropriate investigations. Things like incision hematoma, these may appear right on the anterior abdominal wall where the incision site is, or right on the uterine wall where the incision site is. So sonography becomes key. When you use a high frequency transducer, you are able to evaluate the soft tissue around the subcutaneous tissue and check exactly what may be going on there. At times you have to go deeper, where you have to use a 3.5 megahertz to actually go deeper and check what is happening between the paravesical spaces. So these differentials, they tend to come in. But the key point that is very important in this presentation is to realize that if normal changes in the bladder flap area can be distinguished from the significant hematomas, then appropriate therapy or treatment can be directed, because it's going to give them to say, oh, the incision site is okay, or the incision site, there is ABCD, there is an hematoma of this much. They can go back and remove whatever is there, or they can give some medication or appropriate treatment. So you realize that clinicians, they won't see the bladder flap hematoma. They won't see if there is anything like endometritis. They will have this clinical picture, but they won't know exactly what is going on. You agree with me that diagnosis equals to correct diagnosis equals to correct treatment. So this is the hallmark of this presentation. Our job is to see, do we have any significant hematomas, or can we distinguish the normal bladder flap area that may be there? So by definition, cesarean section is a surgical procedure in which the anterior abdominal wall is cut and the uterine wall to deliver the baby. In simpler terms, we are basically trying to deliver the baby through the anterior abdominal wall by cutting. So the areas that we are cutting, that is our area of consent. Like I mentioned, a transverse incision is more preferred, and then a vertical incision, it can also be done, but it has a risk of incision or hernia or nerve entrapment. So symptomatic patients, like I said, they can be assessed by ultrasound, and the lower uterine segment and the posterior of the urinary bladder may be appreciated very well. So what things do you expect to see? You can find a subfacial hematoma. This subfacial hematoma, this is an hematoma that you can find right on the anterior abdominal wall. Around there, you may have this subfacial hematoma. It's very important to report on it. I should mention that these subfacial hematomas, sometimes they may also develop into scar endometriosis. That may also present there, because sometimes the endometrial tissue may also be left within the scar, and this may arise to that. A bladder flap hematoma, which is one of the most common lesions, may also be found. In my practice, I think I've seen these, maybe quite a number of them, and half the time, I think patients have been given correct treatment with comprehensive approach. Endometritis, ultrasound may not really be very specific, but you need to correlate with other clinical findings that may come. Parachoric gutter lesions or hematomas may also be seen within the parachoric gutters. This may be due to inadequate aspiration during surgery. Remember, as you are cutting, there is bleeding that goes on within the site of incision. So bleeding may be there, but because of poor or inadequate aspiration of blood within the peritoneum, this may result parachoric gutters, hematomas that may also present. But sonography of the post-Cesarean section site can help to actually appreciate or evaluate the integrity of the incision site. So normal appearance of the uterine, lower uterine incision becomes very key. And I'll quickly go into the indications which I've already given. So a patient will be brought with pyrexia of unknown origin to Cesarean section, leukocytosis. These are raised white blood cells suggesting of infection. Abnormal distended urinary bladder, post-Cesarean section. These all patients may also be presented. In my practice, I've witnessed one case where this patient was brought, and the ureters were injured. So immediately after 2 hours or so, the urinary bladder was distending, the stomach was distending. When the patient was brought, I think they realized, oh, there was something that was wrong. They had to go in. So such indications may present even in our centers, and we have to quickly guide clinicians whenever we are doing that. What is the technique? The technique is nothing from the usual. You can use a 3.5 megahertz to penetrate deeper structures like the uterus itself, the paravesical space, the parachoric gutters, the ones we've mentioned, also the anterior uterine space. And also you can use a high frequency 12.5 or maybe 8 or 10 to evaluate possible hematomas from the incision site. So these two becomes very key. Patient can be examined in supine, preferably, and then you let the patient to have a full urinary bladder. The reason is very simple. You want to appreciate the interface of the anterior uterine wall and the posterior urinary bladder. So this becomes key. As people who are working on ultrasound, I think there is nothing unusual about this. So what are the sonographic findings? So for symptomatic patients, for asymptomatic patients, for those who are not presenting with any clinical findings, the following can be found. One, you may find an hypoechoic oval centrally located distinct echogenicity lesion, which can be less than 3 centimeters. That can be a normal site of incision. And remember, I talked about this. They use the sutures and they intertwine that area. So that may be a site of incision. Of course, you won't find it intact. The fact that that area was injured. So you remember there's healing, there was a bit of bleeding and stuff like that. But typically, lesions of such nature in patients who are symptomatic, which are less than 3 centimeters, we are okay to say this is possibly the normal incision site. It may also present with a bit of, or sometimes air within the incision site, which may present as small punctate high echoes. In ultrasound, small punctate high echoes may present like repeated reverberations, more like you're seeing some speckles that are coming out due to that space within the air. So these may represent the sutures. So that is very important to note. And this comes to artifacts. So it may present like a reverberation kind of, very small, but reverberation kind of appearance, but that may represent sutures. A small round hypoechoic mass, again, can be seen adjacent to the uterine incision. It may be distinct from the normal repair. If it's less than 1.5 centimeters in length, there are different measurements, but this is the average, like less than 1.5 centimeters when you measure it. This may be an hematoma, but it can be insignificant. But it's very important to mention and also make follow-ups. But the key message is that it may be an insignificant hematoma that may present with those patients who are symptomatic. For symptomatic patients, remember I talked about they may present with pyrexia of unknown origin. They may present with leukocytosis. They may present with the reduced hematocrit. They may present with other things. So you start from the subfacial hematoma on the anterior abdominal wall. So the size of these lesions or hematomas may range from 3 to 9 centimeters on the anterior abdominal wall. This may present a subfacial hematoma. And a bladder flap hematoma, this is an hematoma that can be found between the posterior urinary bladder wall and the anterior uterine segment. It may range from a large to a complex hypoechoic mass in or around the incision site of the uterus. It may present like that, but there must be clinical evidence of endometritis. So this may also present like this is a bladder flap hematoma. The major issue is to look at the size, how big is it and where is it? And patients may present with that clinical evidence of endometritis, which may be evidenced when you do some other lab investigations. These lesions may also coexist with subfacial and the bladder flap hematoma, which may be secondary to uterine atony, like I mentioned, which may be a possibility in such patients. So these may also coexist. At times you find a complex mass in the right paracortic gutter. This, like I mentioned, this can also present an hematoma due to poor, inadequate aspiration. Remember the paracortic gutters, this is nothing but, this is the area within the peritoneum, and you find that there are these clotting that are going on. So you may find them. So there is nothing wrong for a sonographer. They bring a patient for post-cesarean section. You do the whole abdomen. You check if there is any fluid within the Morrison's pouch. Check around what may be going on. You may find that there is a lesion there. Again, you need to have a very good equipment so that you can delineate the structures around so that you are able to see even these distinct masses that you can see. Retained product of conception is one of the indications for a patient post-cesarean section. Our job is nothing but to give the appropriate in results that we may find. So echogenic contents within the endometrial cavity may suggest retained product of conception. But again, you need also to quantify. Remember, the incision site may also bleed. So literature has continued to mention that less than 10 cc of retained product of conception, they are insignificant. So yes, you may see some small clots that may be there, but if you quantify them by doing your volume of that, if it's less than 10 cc, which is a 10 centimeter cubed, that is insignificant. You can mention there are echogenic contents within the endometrial cavity, but they approximately this much. So you can give that kind of information so that they are aware. The patient may be bleeding, but he may have that. So like I've mentioned, patients with this, they will always present with that, but making a distinction between the normal incision bladder flap hematoma becomes very crucial in these patients. And it aids in the care and the treatment of post-cesarean section patients with fever and leukocytosis. I've already talked about this, where evaluation of the incision site is very, very important. You need to identify the site of incision and measure in both AP, longitudinal, and the transverse. Patients must feel the urinary bladder and they must be noted as such. So normal posterior change, post-operative changes of the lower uterine segment appear as an oval, symmetrical, distinct echogenicity area. So I'll show you how it will appear. So a normal one, it will appear like a centrally distinct oval area, consistent with suture and the incision site. But an abnormal one, it will give you a fluid around. There will be a lesion that can be more than 3 centimeters, 2 to 5 centimeters and above, and that may present as an abnormal site. So this is a bladder flap hematoma. When you look at this rectus muscle, which is just on the anterior abdominal wall, you have this incision. Sorry, you have this hematoma that is just anterior to the uterus, and this may also, this was a sagittal, sorry, this was a transverse view. So you may have this lesion that may be just adjacent to it, and you can also see that the uterus is just below here. And then always scan your images at 2 orthogonal planes so that you can appreciate the site and the location of the lesion that you may be dealing with. Again, sometimes the lesions may be very small, but they may present also like that. So when you look at this, we've got our uterus there. Of course, this was a trans-abdominal flow. Then you've got your lesion that is just there. So this was a patient, I think, two hours after post-cesarean section. And then this is our bladder flap space that we are talking about. This is a urinary bladder. And then we've got our space that is in between there. So sometimes you see these patients who may have this site where there is fluid collection, there are lesions and masses just within there. So you can find that these may also present with the hematomas within there. This was a patient with a full myometrial defect. When you look at this is a myometrium that is within here. And this is our endometrial cavity with a bit of fluid collection within there. And then you can see the distance from here to there, all the way. This was a full thickness defect. Uterine dehiscence may also present like that. But a patient with this is basically presenting the incision site. And depending on the bleeding, these patients, if their hematocrit is dropping, this may also actually, they can bleed more than this, and it can also spill into the paraviscal space. But the key issue is to understand the approach of this. I should mention here that the TVS also plays an important role to appreciate the approach on this one. This was also after a C-section, 48 hours after a C-section. You realize that color was applied, and this was a TVS. And you can see that there's a lesion there with the increased flow of blood. So knowing that there is a lesion there, you have to relate exactly what you're looking at. And this was an hematoma. It was a bladder flap hematoma again after a C-section. Conclusion. Oh, sorry. I think there are some more images that I needed to show you. But the key message on this bladder flap hematoma is that hematomas in the bladder flap may be more than 2 centimeters. They are clinically significant. And the normal low transverse incision site post-Cesarean section can be identified with sonography and distinguished from the hematomas. Sorry, I think there is one image that I needed to show you. But the take-home message is that as you do your sonography, you must remember that these sonographic techniques, they can help and guide clinicians to give the appropriate decisions when it comes to treatment. Not only that, our technique in sonograph must also be very, very accurate and use the appropriate techniques. By appropriate techniques, I mean we must also use the high frequency transducers to evaluate the superficial anterior abdominal wall incision site. We must also consider that we have to go deeper and evaluate the parachoric gutters, the retroperitoneal space, and also the peritoneal space. The whole idea is to correlate the clinical presentation of the patient and exactly what you are seeing on the sonography images. Otherwise, this is what I thought I should share, short as it may be, but these are the real situations and cases that we tend to face in our daily practice of ultrasound. So, and those were my references for those who may want to read about them. Before I close, I should also mention that these techniques, if you read the literature about low incision Cesarean section, there isn't much that has been done, maybe in the African context, where when I was looking at the literature, really, there isn't much, unless people are yet to publish some information. But these are some of the things that we can write on and basically see what is really going on and can we play a role rather than just sticking to do the female end, the BPD, the uterus, and the echoes and everything. But these are some of the few simple things that we can do and bring out some papers that we can write. Otherwise, thank you so much for your attention, and I'll hand over to the moderator. Thank you.
Thank you so much, Mr. Cuthbert, for an interesting presentation. We normally do these kind of cases, but you have brought in a new idea. Now that we now know and we now have the knowledge, we are going to do enough justice for a patient who is coming for a pelvic scan post-Cesarean section. Thank you so much. So you can unmute your mic and ask your question.
Yeah, good evening, everyone. Thank you so much for the presentation, and we were learning. Yeah, so I just wanted to ask, just a few days ago, I had a patient, female 26, with history of an ectopic pregnancy, which was removed. Then later, when they came for a scan, there was no evidence of hematoma, but the only thing we saw was a cyst, yeah, on the right adnexus. So I wanted to ask, is there a relation in terms of infection that could have gone there during the time of operation, or is it something new that has come up?
Okay.
Yeah, I don't think my question is clear.
Okay, so in short, if I've gotten you right, you are trying to relate the cyst which was found on the either, maybe was it on the right or on the left? Are you relating it to the ectopic pregnancy which was found?
Yes,
you want
because
to know Yes.
Yes, because the patient came 3 weeks after the operation with abdominal swelling. So they were trying to rule out hematoma, but the patient was very stable. But the only thing that was there was a cyst. But the
Okay.
initial diagnosis was trying to rule out an hematoma, which we
Okay,
never
so
found.
okay, maybe just a quick question. How big was the cyst?
It was somewhere 7 by 5.
7 by 5. And where was was it on the same side where the ectopic was?
The patient wasn't clear on which side the ectopic was, but the cyst was found on the right adnexa. But the patient didn't give me the correct details in terms of where the ectopic was located.
Okay, in my opinion, it would be very difficult for me to just comment whether it was related. One, we needed to know, was the cyst complex? Did it have any solid components or low-level internal echoes? And was it just a simple cyst and that much? And a
It was a
cyst
simple
of,
cyst.
okay, so a cyst of, you said 7 centimeters plus.
Yeah, 7 centimeters by 5 centimeters in 2 dimensions.
Okay, so as literature continues to emphasize, a cyst with that much, you are likely to have an ovarian portion if it was really an ovarian cyst, because